Every infection that we choose not to cure is an opportunity for that to be spread to someone else in the community. And so in addition to there being kind of individual impacts, there are also widespread public health impacts of not ensuring that people can get access to the healthcare that they need, and also that they have the support to successfully complete treatment.
Welcome to the Pharmacy Quality Solutions Quality Corner Show, where we believe that quality measurement leads to better outcomes. Let us become your go-to source for all things related to quality and medication use in healthcare. We will hit on trending health topics as they relate to performance measurements and find common ground for payers and practitioners. We will discuss how the Equip platform can help you with your performance goals, and we will also make sure to keep you up to date on pharmacy quality news. So buckle up and put your thinking cap on. The Quality Corner Show starts now.
Hello, Quality Corner Show listeners. This is your host, Nick Dorich, and we welcome you back to the show. We hope you enjoyed last week's episode, which focused on social determinants of health and the role that good data-driven policy and improving those sources of data plays for the topic. We mentioned last week that it would be a two-part mini-series, and this is the second part of that series. For this episode, we are introducing a new guest to the show, and I hope you enjoy her insights. Without further ado, I'm now introducing our guest, Adrienne Simmons. Adrienne, welcome to the show.
Thank you so much for having me. It's a privilege to be here.
Adrienne, we brought you onto the show today with the intent to further explore social determinants of health and to go through some practical examples of how data related to social determinants of health can improve patient care. Before we do that, let's get to know you. What is your background as a pharmacist? What is your day job now? And what are you passionate about when it comes to pharmacist and patient care?
Well, I am a pharmacist by trade, but an advocate at heart. I am originally from rural Southwestern Virginia, and I currently work in a non-traditional role, serving as a director of programs at the National Viral Hepatitis Roundtable, also known as NVHR. NVHR is the policy and advocacy arm of a community-based organization located in Seattle that provides healthcare services to people who are impacted by viral hepatitis, as well as substance use disorder. As the only pharmacist in my organization, I have the privilege of working with patients, providers, public health partners, and other community-based organizations, as well as policymakers, to advocate for marginalized communities, which is my passion. So that includes people living with viral hepatitis, people who use drugs, communities of color, people who are experiencing homelessness, as well as people who are incarcerated. I am a graduate of Virginia Commonwealth University School of Pharmacy, and I recently completed a 2-year health system pharmacy administration and leadership residency at the University of North Carolina Medical Center.
Thank you, Adrienne, and thanks for the background. I know it is a very unique role that you play, and it's very interesting to me that you're the only pharmacist involved with that or working in that organization, but it's better to having one pharmacist is better than having none on any team. I think that can be a general way of life. So great to have you there and promoting the role of the pharmacist and how pharmacists can help support patient care. With that introduction, I do want to jump into the content of our show. But before we do, I'll provide a quick overview of what comes next. There are 3 questions written down for us to explore. I'll go down the list and ask the first question. Adrienne, you'll get a chance to respond. Then we may have some back and forth to summarize the key points. We're going to repeat that process for the second and third questions, which will wrap up the primary content for this episode. When we get to the end, we'll have a exciting closing summary, and that'll be it for this show. So with that, let's go ahead and jump into question 1. Now, Adrienne, last week with The Beauty, we spoke about the importance for improving data so that we can improve care for patients and better understand social determinants of health. With your role, you work in an organization that focuses on patients and some unique or more rare disease states. The purpose for today's conversation is to discuss how social determinants of health and improved data can better improve the care and reduce cost of care for these patients. Let's go ahead and discuss our first specific use case on social determinants of health and how that impacts patients. One disease that can have an incredibly high cost of care, obviously being hepatitis C. And there are some amazing therapies that can now treat or even cure the disease, but it doesn't mean we have solved treatment for each and every patient living with hepatitis C. Adrienne, our question for you, how do social determinants of health impact access to care and the successful treatment of patients that have hepatitis C?
Awesome. Thanks for that question, Nick. As you can imagine, there are many social determinants of health that impact access to care for people living with hepatitis C. I'd like to start with talking about health insurance and discrimination against people who use drugs. Just to provide a bit of background about the landscape of hepatitis in the United States, we're seeing increasing rates of hepatitis A, hepatitis B, as well as hepatitis C across the country. Today, we're going to focus on hepatitis C. We'll start with a little bit of history about the treatment for hepatitis C. So when direct-acting antivirals, which many of you know is the cure for the hepatitis C virus, were approved in 2013 as the first curative therapy for hepatitis C, the assumption was that the number of people living with hepatitis C was largely concentrated among people born between the years of 1945 and 1965, also known as our baby boomers. Prior to 1992, most people infected with hepatitis C were infected through blood transfusions for routine procedures or surgeries, because at the time, we were not screening blood transfusions for infectious diseases. However, in recent years, the opioid crisis has fostered a new wave of hepatitis C infections among younger people who inject drugs. Unfortunately, we live in a country in which the existence of a curative therapy, in this case, a deadly infectious disease that can be cured by taking a pill a day for about 8 weeks, does not mean that everyone has access to curative therapy. And so due to the cost of direct-acting antivirals, insurance companies immediately implemented prior authorizations to help restrict who could access treatment, effectively determining who is deserving of a cure. My organization, the National Viral Hepatitis Roundtable, works with the Center for Health Law and Policy Innovation up at Harvard Law School to actually track prior authorization criteria for hepatitis C treatment across state Medicaid programs. And so we primarily track this criteria based on 3 restrictions. The first is fibrosis, or the severity of liver disease. There are many states, particularly when these DAAs came out in 2013, that restricted access to treatment based on how sick someone was. And so a state would say, until you have severe fibrosis, perhaps nearly cirrhosis, you are ineligible for treatment, which, as you can imagine, the progression of liver disease isn't always a linear process. Some people will progress more quickly than others. And we had a number of folks who unfortunately would have to progress to cirrhosis. They may even end up developing liver cancer and needing a liver transplant, all because we could not provide them access to therapy based on their insurance criteria. The second criterion that we track is sobriety restrictions. And so states will actually require patients who use drugs to abstain from drugs or alcohol in order to be eligible for treatment. And they'll require you to be abstinent for a certain period of time. When DAAs first came out in 2013, many of those restrictions were as stringent as requiring someone to abstain from using drugs for 12 months before they could access hepatitis C treatment. Today, we've definitely seen a lot of improvement in these restrictions, but it remains the most pressing restriction that needs to be removed in order for the majority of people today who are living with hepatitis C to access treatment, given that it's being driven by the opioid crisis. And then the third criterion that we track is prescriber restrictions. And so a number of states actually require hepatitis C treatment to be prescribed by a hepatologist, an infectious disease specialist, or a gastroenterologist, despite the fact that we know treatment today is very simple. There are many pharmacists all over the country who are prescribing hepatitis C treatment through collaborative practice agreements, and it isn't rocket science. And so the fact that states continue to restrict access to certain prescribers limits the access that people have to therapy. And so circling back to the social determinants of health piece, health insurance is certainly a social determinant of health. But in this particular case, people who have insurance still can't access treatment. And so when you think about who the demographic is that might be most impacted by the opioid crisis or most impacted by hepatitis C, those tend to be lower income people who rely on Medicaid to ultimately access healthcare services. And so if a Medicaid program is restricting who can be provided treatment, we still end up with this growing pool of people who could be cured of this disease, but instead are being forced to wait for treatment until they have cirrhosis or until they are able to abstain from drugs and alcohol for a certain period of time, which, as you can imagine, is quite challenging, again, within the healthcare system that we have. And we certainly need to make a lot of progress in terms of the availability of substance use disorder treatment, which, again, just complicates the picture of hepatitis C as well as hepatitis A and hepatitis B. And so the challenging thing about hepatitis C treatment access is that there are no other diseases that have these criteria in place. And so if you think about the sobriety restriction in particular and how discriminatory that restriction specifically is, I oftentimes will draw the analogy to other disease states. And so if you have a patient living with diabetes, for instance, and let's say that they, ate a dozen of donuts and they ate McDonald's for 20 days in a row. And so they come back to clinic and their sugar is not controlled. Well, we're not going to refuse to treat their diabetes just because they had a lapse in their diabetes control. Similarly, with sexually transmitted infections, we wouldn't refuse to treat someone who's been reinfected with syphilis just because they were reinfected again. And so I think, this condition in particular is one that we're going to look back on in 10 years and be just amazed at how egregious these restrictions have been. Again, all with the intent to control costs. But the fact that we restrict access to a curative therapy and that those restrictions are really rooted in stigma and in discrimination against people who use drugs is incredibly problematic in the society that we live in today.
Thanks, Adrienne. And with that, it actually had me thinking a lot about our opioid series that we did in the month prior. We talked about harm reduction. We talked about appropriate treatment, use of medications there that can be helpful for those patients. And as you were describing this, a lot of lessons, it's reinforcing a lot of the ideas I've been hearing recently from guests on the podcast. As you mentioned, the treatment or cure for hepatitis C, it's been around or improved since 2013. That may seem like a while, but in the course of medication knowledge, that's actually a relatively small window of time. So it goes back to what we heard from Vibuti last week, where sometimes no data is better than bad data. And when you're talking about how we treat patients or how we have patients access to therapy, if we're creating these restrictions or barriers, that may actually reduce treatment for the patient. It can lead to disease progression, which ultimately is going to be increasing cost for that patient or their insurance plan or the state, whatever that may be. So, that part of it there becomes really key. And I'll pitch it to you. Is that a correct summary of where, if we're whittling it down to a 1 or 2 sentence summary, is that the point here that we need to hammer home for everyone?
That's absolutely the point that we need to hammer home for folks. There are long-lasting consequences of sometimes the best intended policies and processes that we have to put in place to be able to provide services with limited resources, but they have long-lasting consequences. And this is just one of many examples of the way that plays out in real life. In addition to health insurance and discrimination, housing and incarceration are 2 additional social determinants of health that disproportionately impact people living with hepatitis C. We've talked about, hepatitis C treatment is effective, but it's still expensive. Well, as you can imagine, people who are experiencing homelessness have difficulty safely storing their medications. Medications can be lost, they may be stolen. We also dispense the majority of hepatitis C treatment from specialty pharmacies via mail order. Well, mail order requires someone to have a stable physical address. And so for someone who is unstably housed, accessing hepatitis C treatment can be particularly challenging. And then similarly, people who are incarcerated, who again, we know are disproportionately impacted by hepatitis C. There are estimates as high as 50% of people who are incarcerated living with hepatitis C. And these jails and prisons have very similar restrictive criteria to accessing treatment that we see insurance companies enforcing in folks who have re-entered into society. And so they may require you to have advanced liver disease. They may require you to agree to take medication-assisted treatment in order to access hepatitis C treatment. And so these are, every infection that we choose not to cure is an opportunity for that to be spread to someone else in the community. And so in addition to there being kind of individual impacts, there are also widespread public health impacts of not ensuring that people can get access to the healthcare that they need, and also that they have the support to successfully complete treatment.
Yeah, it's a key example, Adrian, for why we need advocacy groups, why we need patient support groups, and groups like yours that are representing and providing the perspective from the patient as well, talking with providers, talking with other organizations. So it's medications, they work when people take them, but we need to make sure that those people can get medication in a way that's going to support them utilizing it appropriately. We'll move on to our second question. We started with hepatitis C because it's somewhat the obvious place to start due to high cost of care and some of the restrictions, but there are many other disease states for which social determinants of health are a priority when managing care for the patient. So Adrienne, do you have any other examples that you would like to identify that may not be as obvious for the pharmacist or any other healthcare provider that we can dig into for today?
Thanks, Nick. We also talked a little bit, we touched on mental health and psychiatry in our hepatitis C discussion as well, and that's certainly another disease state that social determinants of health have an incredible impact on. But, the take-home message here today is that pharmacists should be thinking about every single disease state when it comes to social determinants of health. If there's one message that I could leave folks with today, it's that social determinants of health impact all disease states. As pharmacists, we understandably focus on the clinical aspects of medication therapy, but in reality, the clinical piece plays a minor role in someone's ability to be successful on treatment. It's not just about being able to pick up your prescription from the pharmacy. It's also about whether or not you have access to nutritious food. It's about whether you have a safe place to store your medications. It's about whether or not you have transportation to pick up your medications, as well as the support systems, whether that's familial support or community support, to ensure that you can take therapies that aren't always the easiest to take and may not always make you feel the best. And so having someone to help encourage you to complete therapy is extremely important. So whether that's taking a pill a day for 8 weeks in the case of hepatitis C, or if it's taking HIV medications for the rest of your life, or taking a blood pressure medication for the rest of your life, there are social determinants of health that we have to be considering for every single patient and for every single disease state.
Adrienne, it sounds like the point you're really trying to make or focus here is that for these patients, social determinants of health, whether it's race, economics, social status, et cetera, it has an impact for these patients, but the disease states don't care about any of those sort of things. So it has to become important for us as the healthcare provider to have a focus and to interact with the patient, understand those components of it, because that part's key. The patient wants to know that the provider is understanding and hearing them, and that builds the trust in the relationship so that the medication and the action plan can be effective. We'll now go to our third question, and it's actually going to be the same question that I gave Vibhuti last week to finish up our conversation. How can community pharmacists help to identify and collect data so that social determinants of health can be better understood, be incorporated with quality measures if applicable, and be incorporated with healthcare policy?
It's really simple, and it's as simple as asking questions about what barriers your patients might be facing. I was a technician in a retail pharmacy for a number of years, and reflecting on that experience, there were many, many times where I found myself explaining a rewards program to someone that was coming to pick up their prescription. And I think about all of the time that it could have been spent asking them if they had difficulty getting to the pharmacy that day, or asking whether there were any days where they or anyone in their family went hungry because they didn't have enough money for food. These are the types of questions that don't take up a lot of time, but have an incredible impact, and again, help support someone to be successful in their medication therapy. There are a handful of social determinants of health screening tools, a number of which pharmacies have used to start to gather some of this data, but I have not seen them widely implemented. And so it would be great to see a push from the community pharmacy and the community pharmacies and community pharmacists, as well as their technicians, to advocating for this to be a routine part of care provided to patients. Anytime that someone comes into your pharmacy, and that doesn't mean recognizing that there are also time constraints, and there definitely has to be thought given to how this is integrated into one's workflow. But at the same time, we have an opportunity, I think, to get creative. And maybe it's not asking all questions every time someone comes into the pharmacy. Maybe there's a way to ask one of these questions each time someone comes to the pharmacy. If someone's coming in to see me every couple of weeks, well, by the end of a month or two, I could have gathered data on a number of these questions and had the opportunity to intervene and hopefully provide some additional resources for someone. So I think that it is possible, but the important part to remember is that we have to have the data in order to design effective programs and to know where and when to intervene. And right now, it's just not part of our workflow.
Adrienne, that's a great point. And to kind of put it in another way, we need to think of it like a marathon, not a sprint, right? With each of those patient interactions, there are some disease states, and there are some instances where we're going to need to address the patient and the medication use or the other right then immediately as an acute disease state. But especially in a community pharmacy, it's a patient that you're going to be seeing month by month by month, or routinely for a lot of perhaps the rest of their lives, depending on the disease state. So it becomes an important relationship for how are you maintaining and building that relationship, that trust with the patient, and having a medication action plan, or maybe it's not medication action plan, right? It can be a health and wellness plan, because ultimately, again, depending on the disease state, we want to have those patients on as few medications as needed to effectively treat any disease that they may have or side effects from other medications. So it becomes, again, it's a marathon, not a sprint for most of these interactions. Well, great, Adrienne. I really thank you, first and foremost, for joining us on the show today and for sharing your insight as both a pharmacist and as a patient advocate. I think it's really interesting. I'm sure there's a lot of folks that would love to be able to claim that role or title as part of their day job. I think every pharmacist is a pharmacist and a patient advocate in their own unique way, but to really get to do it every day is a great experience. So you're being an active voice of the patient experience, and its important role that every healthcare provider, not just pharmacists, but every healthcare provider does provide. It was also interesting to hear from someone that has actively worked as a pharmacist, someone that works in pharmacy, but someone that works in a pharmacy adjacent or non-traditional role. But before we wrap up, there's always one final question that we have for our guest. And Adrienne, I'll admit, I don't mean to embarrass you, but I do want to recognize that you are the 2021 APHA New Practitioner of the Year. So round of applause. And that's the award given each year where APHA, or the American Pharmacist Association, recognizes a pharmacist that graduated within the last 5 years. So Adrienne, all the great work that you've done, and you've still yet to hit that 5-year mark since graduating pharmacy school. What or who do you credit for your active involvement and passion for patient care and continued involvement with advocacy?
Thank you so much. I am not one who it's difficult for me to be in the spotlight. And so this I very much appreciate, and I'm humbled to have been chosen as the New Practitioner of the Year. I have an incredible village of friends, family members, as well as mentors to whom I owe all of the credit for my success thus far in my career. I was very fortunate early on in my pharmacy school career to be connected with some mentors who also had a passion for health policy. And that has really just catalyzed my passion for policy and advocacy and set me on a path that really allows me to do something that I love every single day. I would be remiss if I didn't also say that the people that I have had the opportunity to work with in my current role, namely people with lived experience with hepatitis, as well as lived experience with substance use disorder, are the motivation and the reason that I do what I do every day. I have learned an incredible amount from patients they have so much expertise, and I think that oftentimes as healthcare providers, we can discredit patients because they may not have as many letters behind their name as we do, and we assume that we are the experts. But lived experience is also expertise, and I am fortunate that they have been so willing and welcoming to me in this new role. And I think it's important to, as anyone goes throughout their career, to keep an open mind and to be willing to be led by people who may not have as many degrees as you do, but that really have all of the experience and wisdom in the world to share with you. So just a special thank you to my village, and I will also shout out specifically Dr. Vibhuti Arya as a incredible mentor of mine, as well as a dear friend.
Adrienne, thanks for that answer, that response. I would also commend you. One of the pro tips that's generally given about recognizing or thanking folks is that if you start going with specific names, usually someone gets left off the list, and you led with your part of the village. So that encapsulates everybody that's there. So nobody feels left out. Well done on that part. All right, Adrienne. And now the actual final question. I'm sure listeners, and I'm sure those community pharmacy, I'm sure those that are patient advocates may want to hear from you or may want to contact you directly. Is there a best way for them to reach you if they do have questions?
Absolutely. You can DM me on Twitter at Adrienne_RX, or you can shoot me an email at Adrienne at N as in Nancy, V as in Victor, H as in Harry, R as in Robert.org. I'm more than happy to connect with folks. I would also encourage you to go follow our Instagram page. I lead an advocacy Instagram page with a dear friend of mine. So you can find us on Instagram at Dose of Advocacy. And I'd be happy to chat with you further.
Great. All right, Adrienne, well, thank you again for appearing on today's episode, providing your insight. Much appreciated, and a different look at disease states that we don't typically get to explore on the show. So I greatly appreciate that. I'm sure our listeners will as well. Now, for our listeners, I do have some final messages for you. Make sure you subscribe to our podcast if you haven't already. And if you have a question or topic, please let us know. You can DM us on Twitter at Pharmacy Quality, or you can contact us at info@pharmacyquality.com. With that, I again appreciate you listening to the Quality Corner show, and there is one final message from the PQS team.
The Pharmacy Quality Solutions Quality Corner show has a request for you. Our goal is to spread the word about how quality measurement can help improve health outcomes, and we need your help in sharing this podcast to friends and colleagues in the healthcare industry. We also want you to provide feedback, ask us questions, and suggest health topics you'd like to see covered. If you are a health expert and you want to contribute to the show or even talk on the show, please contact us. You can email info@pharmacyquality.com. Let us know what is on your mind, what we can address, so that you are fully informed. We want you to be able to provide the best care for your patients and members, and we wish all of you listeners out there well.